I am ready to go. Good afternoon, everyone here. Welcome to our second week of the 81st session. So I'm excited. We'll go ahead and get started. Madam Secretary, will you please take roll?
Assemblywoman Benitez Thompson.
Here.
Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orndlicker. Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong.
Here.
Assemblywoman Thomas.
Here.
Assemblywoman Titus.
Here.
Chair Wynn.
I am here. And for the record, I didn't know if I heard Assemblyman Ornlicker, but I see him on the screen and I see him trying to do it. So if we could just be present for the record. There we go. Thank you. And I think I'm just going to get started with our first presenter. I know that they have been very flexible given the fact that we had to swear in our newest member into our body today, this afternoon. So like I had said before last week, we are going to do, I can't believe I'm saying this, a deeper dive into some of these like state agencies that are here. So if we can go ahead and turn that over broadcast to the Division of Public and Behavioral Health in the Department of Health and Human Services.
Okay. Hi, good morning. Good afternoon. My name is Lisa Sherrick. I'm the administrator for the Division of Public and Behavioral Health. Here with me today is Julia Peak, slowly coming into the screen, Deputy Administrator for Community Health Services. Also with me today is Ms. Nikki Aker, Director for Carson City Health and Human Services behind me. Mr. Kevin Dick, County Health Officer for Washoe County Health District. And Dr. Furman LeGuen, County Health Officer for Southern Nevada Health District. And we'll share our presentation.
And I think you need to put it in, I think, the full screen view.
Okay. There we go. Can you see that?
Hello, this is broadcast. We are only able to see it in the editing view. If you could either go up to the top and do from the beginning, or when you are opening the screen share option itself, you want to go and click specifically on the application when you open the Zoom screen share and not the monitor that it's on.
Did that work?
No, ma'am. If you could. All right, so if you go into the screen share options, instead of choosing screen 1 or screen 2, if you could pick just the application in which your PowerPoint is connected on, and then just click on that one specifically. And if you press play from the beginning, let's see if that works. There's also an icon at the bottom right hand of your screen. I think you might have clicked it earlier. I'm not sure if that was helpful, but it should give you also the main screen.
if we're not able to get it in the full screen view, they can just go ahead with that in edit view. I don't have well enough eyesight to be able to read those small little screens, but if you would, you could follow around committee members if we're not able to do that. And then again, this is also available on Nellis if you want to further review some of these slides that are presented.
Okay. Are you able to see that now? I truly apologize.
We can see the basics, but if you would like to go forward, the chair has given you permission to go forward with it as it is. If you could please unmute your microphone, we may begin.
Okay, so sorry. Moving to slide 2. Are you able to see me? I feel like I'm not on video either.
You know what? That's okay. We can hear you. We did not hear your opening presentation. We just heard you say going to slide 2. So I don't know if you want to start all over, but we can hear you.
Sure. Okay. So good afternoon. My name is Lisa Sherrick. I'm the administrator for the Division of Public and Behavioral Health. Here with me today is Julia Peak, Deputy Administrator for Community Health Services, along with Miss Nikki Aker, who's directly behind me, Director for Carson Health and Human Services, Mr. Kevin Dick, County Health Officer from Washoe County Health District, who's online, and Dr. Furman LeGuen, who's also online, who's the County Health Officer for Southern Nevada Health District. Moving to slide 2, this provides an overview of our division's vision and mission. Slide 3 provides an overview of our division's organizational chart. Slide 4 provides an overview of our agency's operations. As you can see, we are comprised of 5 service branches: community health, regulatory and planning, clinical, behavioral health policy, and administrative services. Slide 5 and 6 provide an overview of our public health programs. Slides 7 through 9 provides an overview of our division's accomplishments. Of note, I'm particularly proud of the work the Division of Public and Behavioral Health has continued to do related to addressing COVID-19 spread within Nevada's licensed facilities. Compared to the national average of the percentage of deaths in facilities as it compares to total deaths, Nevada has consistently been under 25%, whereas the approximate national average is 40%, with some states as high as 80%. Additionally, Nevada has been under 20% since August, and as of today, we are at 15.8%. And for anyone who had an opportunity to watch our pre-session hearing, that's 1.5% lower than that presentation a couple weeks ago. Slide 10 provides information of our division's public health priorities. And with that, I will turn it over to Julia Peak, who will provide an overview of the rest of our presentation for the Division of Public and Behavioral Health.
Perfect. This is Julia Peak with the Nevada Division of Public and Behavioral Health. Thank you, Chair, for allowing us to talk on public health today. I'm going to do an overview of public health, so I'll be taking the next many slides to talk about public health. And I would start off by saying one of the easiest ways to understand public health is to understand the historical accomplishments in the field. I've provided a link in the PowerPoint of the 10 greatest public health achievements, and I'm going to note just the top 5 right now. CDC notes that that's vaccination, motor vehicle safety, safer workplaces, and that's really related to safety in mining, manufacturing, and construction, control of infectious diseases, and that includes clean water, sanitation, and decline in deaths from coronary heart disease and stroke. And this really centers around risk modification, including smoking cessation, blood pressure control, and early detection and better treatment. The report goes on to list another 5 accomplishments, and it ranges from maternal and child health to other areas. I encourage anyone interested to access the link that has been provided. That said, even in this top 5, you can see the great diversity in scope and responsibility of our public health partners. This next slide is a common diagram that we use to show the public health system. We also call it the Easter egg diagram and have presented it before. It really illustrates the diversity of our partnerships in place to address and improve the health of our residents. Depending on the issue at hand to tackle, the specific partners we work with can vary. Or for example, with COVID, there's not one on here that we haven't worked with to try to address that in our state. Going to the next slide as we talk again about the scope of public health, it is very broad and flexible in scope and responsibility because it relates to the health of our public generally. As a rule, our efforts are driven to understand why people get sick and why they die. Our overarching vision is for each person to live a long and healthy life. If we can understand the health issues in our population and subpopulations, we can try to intervene and prevent that negative outcome. We often find our focus is on infectious disease because it can spread through the population quickly. This next slide is a model that we used often in public health, and we really can speak about the issue as it relates to this. It's called the social ecological model, and it helps us understand the many levels of an issue, especially as it relates to population or public health. So this model starts locally, for example, with the individual and then their peers and family, and then evolves to the highest level, which is the influence of policy. This model helps us understand which level impacts the health issue so we can develop specific interventions at each of those levels. The next slide shows an example. There's many examples. I thought this one was particularly easy to look at. It's related to childhood obesity and is just a good illustration. So for example, with childhood obesity, we look at the child themselves. Their personal demographics are a primary factor in their weight, but also their parents' weight, food preferences in the home. At the policy level in this same scenario, this is where the larger population efforts occur around childhood obesity. So for example, related to obesity, seeing nutritional details on food items or on restaurant menus, those are all things that affect healthy eating and obesity. Also, the taxing of certain items can change behavior, and those are all policy opportunities as we look at obesity and healthy living. Going on, I'd be remiss if I didn't speak about the amazing universities in our state specifically, but nationwide as well. So there's great diversity in the field of public health. And what you're seeing in front of you is a list of the specialties or core competencies that our public health professionals can focus on. And truly, this is a holistic approach to addressing public health. And again, I just want to acknowledge our universities in the state who have been such a pivotal part of our response to COVID in this state. Going on, I know this is a lot of words, but I'm just going to provide a highlight, and I also provided a link. Public health, like all topics, evolves over time. We are in a period of time that is coined Public Health 3.0, where public health professionals a century ago may have focused on very granular outbreaks or a crisis. Now we function more as strategists to pull partners together to look at inequities and opportunities for intervention. Again, a really good illustration provided by the CDC, and we often get asked in public health about our relationship with healthcare. It truly is a partnership where healthcare focuses on the health of the patient in front of them, and we focus on how all the patients together become population health and the health status of the collective group and how to intervene. More on Public Health 3.0, as I mentioned, public health is in constant evolution. With Public Health 3.0, we focus much more on collective impact and reaching our residents where they are. We also understand more and focus on social determinants of health that lead to a particular health outcome. You'll hear a person's zip code is often more a reflection of their health than their genetic code, and that's some of the things we look at as we delve into public health data. And so, for example, you may have health insurance due to affordable health care, but you might not be getting preventative screening, even though it's an allowable service. So in public health, we try to understand why that's occurring. What is the barrier if it's no longer health insurance, and how can we help address that so that we can identify any health issues that you have and intervene. I'm going to transition now from global public health comments to concepts about public health in Nevada. Nevada is one of only 2 states nationally that is considered a largely decentralized public health structure. The bulk of our population, as you know, is served by a district health department, but the state still provides direct service in many counties, and we've also delegated some authority for example, Carson City Health and Human Services. Going to the next slide, the structure and function of public health are in several statutes, but I will highlight just 2, and those are found in NRS 439 and NRS 441A. These have been of particular interest over the COVID response, but again, there's many. You'll hear later from our 2 district health departments who function largely as independent health agencies, as well as Carson City Health and Human Services, who operates as a regional health department under delegation of authority that's allowed in that law. One of the things that we had to work on a great deal on the next slide is the county boards of health. I'm focusing in this case specifically on our rural and frontier counties related to the population side in this statute. Each county is required to have a county board of health. It's representative of the county commissioners, the sheriff, and a health officer. And we work a great deal with the health officer that's designated. One of the challenges that we had as it relates to COVID is every rural county looked different. In some rural counties, they had a very functional board of health that was meeting on a regular basis and tackling population health issues locally. In some cases, they didn't have a board of health, and trying to have that stood up and identify a county health officer in the midst of the COVID pandemic was problematic. That said, the counties have moved mountains in this regard. And so now I think that functional necessity of a public health system at the county level is incredible. So I do just want to acknowledge all the efforts there. They've really stepped up. The next slide is a very short list of what we've learned. I could certainly talk much more on this, but so too can our public health partners that'll be coming up later. What we found is in public health, as I mentioned with that Easter egg diagram, we have such a variety of partners that we work with when we address a specific issue. But one of the challenges here is we had to become the convener in many cases and not the doer. And we had to work with our counties and county leadership, but specifically emergency management. And that group of people locally, including our National Guard and Department of Emergency Management at the statewide level, has really helped with the logistics and to operationalize these incredible public health interventions. We also clearly identified a need for flexible funding to support a public health crisis in real time and support basic infrastructure. As you know, our federal partners did come through with funding for epidemiology and lab capacity, immunization, public health preparedness, and other items. But we did function with what we had for several months in the beginning. We also don't have the ability, really with the exception of COVID funding, to address the need locally. We have many public health crises, and often you'll see Nevada at the low end of a good list because we don't have basic infrastructure funding. I also talked about decentralization of public health. I again can't speak highly enough of how our specifically rural and frontier counties stepped up when they had no infrastructure prior and accepted delegation of authority from our chief medical officer. They have shown such great work. I see great value in watering that effort and continuing to see it grow with other diseases outside of COVID. And that will take some infrastructure funding so that they could set up such structures. Also, one of the biggest challenges for us, we try to get as much money out into the field for direct service as possible because the funds are so limited. So that has meant for years, I'll say in the last 15 years that I've been here, we skimp ourselves at the division on things such as human resources support, IT infrastructure support, fiscal support, because the need for direct service and our county need is so great. But that creates a huge challenge for us in that even with COVID, We received $430 million for the response, but us at the division, we need to get those subawards out, assure that the spending is appropriate and correct, and that's a big ask. And so that's been a challenge for us. Another huge challenge, and I just want to acknowledge all our IT staff out there, is we had a very antiquated system for infectious disease. I believe our lab reporting went up 8,000 times what we were used to, and it really crippled our system. We were functioning largely in some cases on faxed reports, and that quickly became unmanageable. So we've had to use some of this funding, luckily, to develop things within our public health infrastructure that will impact us for all diseases going forward. The other major challenge that we had is the expectation that we could release data in a day. And related to public health, it's typically not real-time surveillance. And so we were really challenged with HIV data, for example. We take a year and a half to clean it before we release it and make sure it's absolutely the most accurate record on file. So those are things that were reasonable expectations of our community and of people who needed that information. It just has been an incredible lift on behalf of the public health structure. The last slide before we go to our local partners is related to public health funding. I had to get a slide in there just to speak about this a little. Each biennium we report on where we are nationally with public health spending. And so according to the American Healthcare Rankings, they say we're the least healthy state as far as public health funding. Alaska was the best at $289 per capita, and we're at $50 per capita. That said, we have had investments in the past several years related to family planning, Women's Health Connection, and other services. So we have done things in the past bienniums, but we are still much further behind than many other states. One report shows that an investment of $10 per person in evidence-based programs can save the country, as you see here, $16 billion annually within 5 years. And one of the important points is who benefits most from public health? It is those children and infants under-resourced communities. A huge ask of us is to identify inequity and disparities and offer suggestions as to how we can intervene and ensure that that is removed. That concludes our presentation at Division of Public and Behavioral Health. I'm happy to take questions with Lisa, or I can turn it over to Nikki Aker, who serves as the Director of Carson City Health and Human Services.
I think I have a couple of questions, and if that's okay. Some of those numbers were really quite impressive, especially in light of the fact that you said that you were talking about how your IT started off with faxed reports, and I was half expecting carbon paper and typewriters, although I'm sure they also exist within the division as well. So I did want to point out that, make a point of, highlighting when our state is a leader nationally. Specifically, you had talked about how our numbers were about half in those long-term care facilities. I think you said nationally it was about 20%. And are 40%, and we were at about 20%, and that was even lower more recently. But can you maybe highlight what it is that we are doing right, and are we sharing those best practice management practices with other state agencies and other regulatory responders?
Hi, Lisa Sherrick for the record. Yes, so what we did early on was create essentially strike teams, and we have always had our Office of Public Health and Investigation and Epidemiology, we call OFI. We also have our Health Acquired Infection team, and then our Healthcare Quality and Compliance team. And so early on, we made a concerted effort to make sure that those three teams were working very closely together, along with the facilities, to identify infection control issues, provide a lot of technical assistance, really coming from the angle of improving rather than punitive. And so we have done work with also the Department of Corrections. Our staff have been out to a couple of the facilities and have provided information on how they can address certain infectious control issues and so forth. I don't particularly have any information as far as what we've done to share with other states, but I can check and follow up and provide that information later.
Chair, if I might, Lisa mentioned the health facility epidemiology team. That is something that's unique to Nevada. And I'll just say we learned from our crises in public health, and we developed that team as a result of a hepatitis C outbreak in Clark County. And we knew that we had to have basically a strike team that could intervene immediately. And so we had those relationships and structure built prior to COVID. And so we were able to come in and just make minor modifications to that. Other states who had not worked so directly with epidemiology and healthcare associated infections had to build that from scratch. And so that's something we are really proud of. The other thing, again, we learned from crisis is that as a result of COVID, we were on separate reporting systems at the districts and the state, and we're all going to move to the same infectious disease reporting system so that we have a standardized way to collect data. We understand that county lines are not solid and that we need to be able to see how people go across the state, especially with infectious diseases. So we're learning a lot, and again, making really foundational public health improvements. And where we do have the opportunity to share with what we're doing in other states, I'll just note for COVID-19 vaccination, we have the highest administration rates in our region, and we're often on calls with our regional partners where we talk through what we're doing, offer suggestions of what's working and what's not. So in that ways, with this crisis, we are a leader in the region.
Thank you. And I believe we have a question. I have a couple people in the queue here, so I'll start with Assemblywoman Summers Armstrong.
Thank you very much, Chair Nguyen, and thank you so much, Ms. Sherrick and Ms. Peak for your presentation. I have just a couple quick questions. Are you collecting demographic information on the COVID rates, and how is Nevada looking comparatively to the national rates of COVID infection and deaths in the Black and Brown communities in our state? I hope that we are collecting that data and that you can report that information. Thank you very much.
Are we on mute? Sorry, Julia Peak for the record. Thank you for the question. We are collecting information on race, ethnicity. We also are one of the only states that added questions related to LGBTQI issues. Again, we don't know a disparity until we look at the data and see if there's truly a disparity in a number of areas. I think we're pretty standard. I'm happy to pull that data for you directly. Not to air some dirty laundry, but I'll explain some of the challenges with public health data in this capacity. We get that data from lab reports. So the cases you see on the NB Health Response dashboard is often because you needed it in such real time to see what's happening with the disease burden. Lab reports, though required by our federal partners now, often don't have race, ethnicity. And so we were going off a lot of data that's unknown and trying to do the investigation of those cases so we could get that added. So it is a huge effort and lift. I hope that our laboratory partners continue to improve in this area because we need to know what the inequities look like in our community. We're also collecting that information related to vaccinations. The governor has reported that he's going to focus hugely on equity as we move forward. Some of the challenges that we do experience with equity is that that's self-reported by the individual, and sometimes they may feel uncomfortable sharing that. So we have to communicate really effectively about why we collect that data, how we're going to use that data. So we're doing a lot of effort in that regard right now. But across the board, Nevada is trying to be as progressive as possible in asking as many questions across all diseases in the hopes that we can find inequity and then address them, race, ethnicity, and otherwise.
Thank you.
And if you can provide any of that data to our committee secretary, and then we'll distribute it to the rest of the committee. And do you have any follow-up, Assemblywoman Summers Armstrong?
I was just going to ask Ms. Peak, if you can tell me as a representative for my community, what can those of us who are elected officials do to help improve the confidence in our communities for them to report this data to you so that you can have better data to report and to collect? What can we do to help?
No, thank you so much. And thank you, Chair, for letting me respond to that question. You truly are the champions in the community. And so what you say will be heard. I think the effort needs to be on our part in public health to get you the talking points and information you need to then go champion that back to your community. So I'll take that away as well and send information out to you all as to specifically around vaccination, but the importance of in any disease and investigation, providing that to the public health partners and understanding that that's confidential, but it's used by us to bring resources to the community and identify if there is disparity. So I'm happy to take that out and get you all some talking points to share with your community, and we'll hopefully address that.
Thank you. And if we can go next to Assemblywoman Titus.
Thank you, Madam Chair. I appreciate the opportunity to ask a question. All of you who are presenting today, thank you so much for what you're doing for the public health of Nevada. I know that this has been a challenging time. It's challenging without a pandemic, let alone what you've had to put up with this last year. And we have communicated many times, and I appreciate that. Recently in the news, there's been some pretty big information about the disparity and the vaccine and who have received the vaccine. And I know that you have heard me ask this question before in the money committees when we talk about receiving COVID funds and where they're going and making sure we have that outreach, as my colleague, Assemblywoman Summers Armstrong asked about, how do you get it out to the folks, get them gaining trust. I know that our Attorney General made a big point when he got his vaccine because he wanted the communities to be reassured that it's okay to get that vaccine, as we know there's a huge amount of distrust in the process, and frankly, rightfully so. My concern is that with these numbers that have come out, it was that, again, there's a significant disparity about who has gotten this vaccine. And I'm wondering if it wasn't because you were following the governor's office when they talked about the different lanes and the different tiers. That can you describe maybe perhaps that's where the tiers fell, that there was the first responders and then the people over 70 in the second tier and some of those criteria. So I just kind of wondered, I know it's a touchy subject, but it needs to be asked, that how was it decided to give those vaccinations? Because I think you just need some clarity that, again, you were just following the tiers that were put out there as a direction, and has that changed at all now that we know that maybe wasn't good enough?
Yeah, this is, thank you for the opportunity to answer the question, Julia Peak. So I'll start off by saying the funding question a little bit, because I think that's an important one. The CDC, the disparities and inequities have been something our federal partners have been emphasizing since the start of the pandemic, and again is reflected in the data we have as well. So related to the vaccination grant, at least 10% of that award has to go directly to addressing disparity in the community and equitable distribution. That includes racial, ethnic disparity, but also specifically called out rural residents. So those are things that each of our local health departments will build into their budgets as they spend that award. There's also an equity task force that's a requirement of that award. In Nevada, we're one of the states that developed staffing within our Office of Minority Health and Equity from the beginning of the COVID response, who's been working with us on testing and how we message that appropriately, and now vaccination as well, as has our coalition. So we'll continue to work in that area. Related to the playbook, I think that's such an important discussion and point. And so if we looked at straight population distribution, then we would look at our folks within a certain zip code getting the level that's appropriate based on their overall piece of the population. And as you mentioned, that's not how this works. It is related to lanes or tiers, and it's been called different things. But we based our playbook and our recommendations on the ACIP recommendations and what our CDC partners said. So it might look like there's inequity in certain, again, zip codes or age groups, but it's a result of following the playbook. Are we perfect? No. Anything we present on can be improved and is not perfect. And so it's a matter of drawing more attention to it, ensuring that we have data collected. And this goes back to the former discussion, as well as how important it is to share information with the person vaccinating you on accurate information on your address, on your race, ethnicity, et cetera, so that when we pull the data, especially when it becomes more general population based, that we can ensure there's a level of equity. The other thing we're doing is looking at how we reach populations that might have a hard time getting vaccinated. So one of the things that we're going to be looking at is mobile outreach. You've seen it before with like the Mama Van, for example, where we can go out into a community and over vaccinate or test that community with that resource. It's going to be particularly helpful when we get a one dose like the Johnson & Johnson eventually to really target specific zip codes. Again, that's most important when it becomes a general population vaccination. We are working really hard again with the equity across the 70-plus-year-olds. The biggest challenge, and you guys have heard this, is just the supply issue at this point. We have a limited number of vaccinations, and so it is challenging for folks to get the resource. One of the things that we've done to implement equity and address barriers presented is develop the call line. Though not perfect, it's getting huge number of calls, and we're walking people through how to do that. So if you don't have a smart device or you're having a hard time navigating the website or the various pharmacy websites for enrollment, you can call our helpline and we'll walk you through that. So again, not perfection by any means, but we're certainly trying to get better eyes on it and better data so that we ensure equity at every level we have control over.
Thank you for that response. If I might follow up, Madam Chair.
That's fine, yeah.
Great, thank you. And so just to follow up on that, I think it would be helpful to have if you could get us some numbers, not just on the COVID vaccine, because again, as you said, this is a unique position. We developed the best plan that we could, and as you said, maybe not perfect. I think there's been some real disparities in getting vaccines in general, and we'll get control of this pandemic, but we may not get necessary control of the need to reach out and get more people vaccinated, not just with COVID vaccine, but with the flu vaccine. We know that we're in the bottom of the number of folks who actually get vaccinated for the flu. I think only 44% of our population gets the flu vaccine. And so this goes far beyond the COVID. But what the COVID has done is really been able to show us our real holes in our system and bring them to the forefront. And I think if we could see some data maybe on what the traditional vaccination rates are across the board for all the vaccines available, and how we need to do better for all members of our Nevada communities. I think that would be helpful too, not just this COVID that obviously is in the news more, but when we talk about we've done better with the flu vaccine this year, we're still lacking on some of the stuff and these vaccines that need to be given or people should consider getting. And so that's more of a comment. So hopefully when we get some of this data that you say you are now gathering, we can have actually, what's the disparity rates in overall vaccines and who is getting them. And then a final comment. I love your clear masks. I like to see the facial expressions, and thank you for sporting those today. And hopefully they become more available, because I think that the facial expressions are critical to communication. So thank you for that. And again, thank you for all you're doing.
And thank you for your presentation this morning or this afternoon. I know we have quite a few other presentations to get to, so and I don't see any questions right now, but if you do have any other further questions, I would ask the members to reach out directly to our presenters. I think we can get you their contact information as well. And I think the next presentation we're moving on to is the Carson City Health and Human Services. And if I can remind everyone to please state your name prior to speaking, just so we can make sure we have a clear record for committee secretaries.
Okay.
Good afternoon. For the record, Nikki Aker, Director, Carson City Health and Human Services. And thank you very much for inviting us and letting us present today. So for Carson City Health and Human Services, we are a county, we have a county board of health. Carson City's municipal code, talking about our county board of health, requires a Nevada licensed doctor, whereas NRS 439 does not. Carson City elected to create a county board of health in 2003. And as Julia presented, the Board of Health composition includes the county health officer, Carson City Board of Supervisors, sheriff, and county clerk. So an overview of our health department. We are a local health authority, not a district. Since Carson City is a consolidated municipality, to be a district, 2 or more counties or cities need to join together, and that's through NRS 439.370. Carson City is a city department of Carson City. Our department received public health accreditation in May 2016 after many years of working on this endeavor. The core documents of accreditation are the county health needs assessment, the community health needs assessment, the community health improvement plan, and the strategic plan. Some other important plans include the quality improvement plan, the workforce development plan, the risk communications plan, and the public health emergency operations plan. And we right now are in the midst of going for reaccreditation. So staffing at the health department before COVID was 38 FTEs, and currently we are at 65.5 FTEs. On this slide here, I do have our organizational chart. I realize it's probably too small for you all to see. What the Disease Control and Prevention Division and PHP organizational charts will be on other slides, and PHP is the Public Health Preparedness. So the budget for Carson City is it's a $9.4 million budget. 29% is general funded, 63% is grant funded. This percentage is higher currently due to the COVID grants that we received, and an 8% revenue. And this revenue also includes an interlocal agreement, and I'll explain what that is on another slide. So one of our divisions, we have the chronic disease prevention and health promotion. The adolescent health program conducts abstinence and comprehensive sexual health classes to youth, and families talking together classes for parents, which teach parents how they can talk to their children about sex. Staff have been researching creative ways to conduct classes since schools are not allowing outsiders in due to COVID. Some of the alternative schools for troubled youth have allowed our instructors to teach in person. We also have a Ryan White retention and care program that attempts to find individuals that are out of care and have been diagnosed with HIV, determine what their barriers are, and help get them back into care and this mainly focuses on the rural and frontier counties. We have our tobacco control and prevention program that focuses on providing educational presentations to youth, discouraging initiation of the use of tobacco products and vaping. We collaborate with the Nevada Tobacco Prevention Coalition and other agencies to educate decision makers and the public on the benefits of policy solutions to address e-cigarette use among youth and young adults. And we continue promoting counter-marketing campaigns about the danger of the use of tobacco products and e-cigarettes. We also facilitate referrals from providers that serve the youth to My Life, My Quit program. And this program is also researching different ways to reach their audience due to the COVID restrictions. One thing that I did not include on this slide is we do have a small grant for diabetes outreach. The staffing for this division is 4.5 FTEs, and this division is 100% grant funded. Then we have our clinical services, and I listed out the services that we provide. We do receive Title X funding directly from the federal government, and we subgrant some of that funding to Douglas County. We receive other funding from the state, either as pass-through grants or from state funding. Currently, the clinic is seeing patients, and we're taking measures to protect themselves as the staff and also the clients from COVID. The staffing in that division is 10 FTEs. That division is 9% general funded, 61% grant funded, and 30% revenue. We do bill different insurances, and we also collect cash payments on a sliding scale for services provided from those that are uninsured or do not wish to use their insurance. Another division we have is our disease prevention and control, which consists of environmental health and epidemiology. So talking on the environmental health side of the division, I have listed the establishments that our health inspectors inspect and permit. We do provide environmental health services to Douglas County through an interlocal agreement, and that's what I was speaking to earlier. Some other duties of our environmental health are also listed here, and please note that a couple of the duties are Carson City only. Staffing within that division is 6.5 FTEs. That division is 34% general funded, 2% grant funded. We've got our interlocal for 55%, and revenue is 9%. And then on the other side of this division is epidemiology. And one of the challenges that we really noticed when the pandemic started was we have both environmental health and epidemiology under one division, and that created some really big challenges, and we'll be looking at maybe something changing in the future. So our epidemiology program is very involved in COVID contact tracing and reporting. You know, along with COVID, there continues to be other reportable disease that need to be investigated. And currently we have 1.5 FTEs working on those other diseases. Staffing for this entire division right now is 16.5 FTEs, and prior to COVID, it was 2 FTEs. We also have some individuals that are helping us that are not included in our staffing. We have 2 from the National Guard, we have 2 behavioral health ambassadors, and we have 2 CDC Foundation employees until March 31st. And we will be putting those into our staffing, the CDC Foundation employees. So this division, it's 2% general funded and 98% grant funded for the epidemiology. And I included the organizational chart. What you see in green is the environmental health, and the rest is epidemiology. So Carson City Health and Human Service is different from other Nevada health authorities by having human services within the health department. This division provides health, welfare, and community assistance as required by NRS, along with some of the other activities that I listed above. FAST, I just wanted to take a minute and talk a little bit about FAST, which is the Forensics Assessment Safety Triage Team. This is a collaboration with other service agencies that go into the county jail, attempting to connect inmates with services while in jail, and so that they will have that upon release. This division has 8 FTEs and is 45% general funded and 55% grant funded. And our public health preparedness, or you'll hear me say PHP. So this division is leading the COVID response since this is a public health emergency. Testing and vaccination efforts are being led by this division, along with working with other city, county governmental entities. We do have delegation of authority from the state and the counties to provide COVID service to Douglas, Lyon, and Story counties in addition to Carson City. So our staffing prior to COVID was 5 FTEs, and we are up to 20 FTEs for the COVID response. We have 1 volunteer testing RN, and we have 10 to 14 National Guard for 2 to 4 days per week. And this division is 100% grant funded. And then I included the organizational chart for this division. So I included our COVID-19 timeline for our response. We have been at this for a year since we started with planning for the repatriation of our 15 residents from the Grand Princess cruise ship. So as part of our COVID response, we have conducted 92 testing events since May, along with testing at the health department Monday through Friday. We have conducted 35 vaccination events since the end of December. And as of May 5th, the Quad County's cumulative, can't talk today, positive cases are 10,910, and we've had 7,934 recoveries. As of February 6th, the vaccinations that we have received are 11,975. The vaccinations given is 11,258. We do have 700 second dose vaccinations that we will be administering this week. Some of our partners include our city and county governments, of course, the state of Nevada, the Department of Public and Behavioral Health, the state of Nevada's immunization program, the state's Department of Emergency Management, Immunize Nevada, the National Guard, area hospitals, our area doctors. And as you saw from Julia's presentation on what I call the jelly bean chart, we've utilized a lot of those partners in this endeavor. And then I included a couple some pictures here. In the lower right-hand corner, you can see we did a vaccination clinic at Carson Valley Inn, and it was snowing that day. This kind of led our decision into that if we can help it, we will not do any more outdoor events, because you cannot predict Nevada's weather. And it was, my staff had a really interesting day that day. And then you'll see on the lower picture in the middle, that is our trailer that has everything in it that we need. And we say that we take the show on the road. So some of our challenges, we have many. We see our challenges as opportunities for improvement. As Ms. Peak talked about, we have a challenge with public health funding. We have seen some big challenges with zip codes that cross county lines, and our public and the diseases do not recognize county lines. Our health department is very lean, which came out from our accreditation site visit. And it was very difficult at the beginning of the pandemic to get the work done. We were working long hours to get it done because we knew we needed to. So we opened up the Quad County Emergency Operations Center. Many of us wear different hats, so keeping up with all of our other duties has been challenging. We are limited on space. Some of you that do know the building that we have in Carson City, we share most of the upstairs with Vitality Unlimited. And so we grew out of the health department very quickly, and we now have 4 different sites. Currently, we are finding sites for testing and vaccination that especially now we want to look at the mass vaccination that we plan to do when we get a higher allocation. But sometimes finding these sites for testing and vaccination can be difficult since we are in 4 different counties. Our IT infrastructure, we really have pushed our IT department to limits, looking at, we needed computers, wiring, we set up a call center quickly, and information, we want it on our website, and that involves a lot of IT work. Our current scheduling system is a challenge right now, and looking at hopefully something to improve on that. Working with 4 counties and 4 separate governmental boards and 4 different health officers does create challenges sometimes because not everybody thinks the same way, which is a good thing. We see as an opportunity in 2003 when the Carson City's Board of Supervisors voted to have a Board of Health, regionalization was being discussed back in 2003. The Quad County concept has been successful for the PHP program. So in the future, an opportunity will be to continue to explore the value of having a Quad County's health department to serve the region with a single board of health. And that concludes my presentation, and I will take any questions you may have.
Thank you so much for that presentation. And I am just going to kind of go to the view. I didn't see anyone reach out to me. Does anyone have any questions? I'm at the gallery view here, so I can take a look here. Anyone? Okay. Thank you so much for your presentation. And like I said, all the other members can please, all these presentations are also on Nellis. So if you want to follow up, you can follow up with that information if you want to do a more detailed look at some of these programs that are being performed around our state. So without further ado, I think the next person on our list is Mr. Kevin Dick with the Washoe County Health District. Is that correct?
Yes. Good afternoon, Chair Nguyen, and
Perfect.
thank you for all the members of the committee for allowing me to present today. I believe that Mr. Felipe is going to advance the slide deck for me. So I'll see if, there we go. So I'm Kevin Dick. I'm the District Health Officer for the Washoe County Health District. And next slide, please. The Washoe County Health District is established under NRS 439 under the provision for counties with a population of less than 700,000. And that provides for cities and the county to come together to establish a health district. And that was done formally in 1972 through an interlocal agreement between Reno Sparks and Washoe County. We have a 7-member district board of health that is 2 members that are appointed by each jurisdiction, one of which is elected, and those 6 members appoint a physician as the 7th member of the Board of Health. And per NRS 439, we have jurisdiction over all public health matters in Washoe County. Next slide. So the mission of public health is to protect and improve the health of the community. And so it's a population and community level approach, as Ms. Peak mentioned, which makes it quite distinct from healthcare, which is providing medical care to individuals. And so as part of this activity, we assess the health status of our community. And in that work, we identify what are the factors that are driving mortality and morbidity in our community. And we find that inequities in subpopulations that are shaped by demographics and social and economic disparities are driving a lot of the poor health outcomes that we see. I like to compare public health to an intelligence agency. And for the most part, we operate 24/7 quietly in the background, and we identify public health threats, and then we develop strategies to eliminate or control them. And if we're successful with that, nobody really notices us and what we do. It's pretty difficult to hide a pandemic. And so we have been very visible in the news as we've gone through the past year or so with COVID-19. But usually the community is not so aware of our activities. But we're conducting surveillance. We get the reports of the reportable diseases that are identified by the labs under NRS 441. We also have some near real-time surveillance that we use where we look at the ambulance response and types of cases they're responding to, the emergency departments and admissions into the hospitals. We have an intelligence platform that provides us with information about medications that are sold over the counter at pharmacies and drugstores in our communities. And then we also use disease prevention to control and prevent disease. Part of that is the disease investigation work that we do on those reportable diseases. Immunization programs are a component of that. We have regulations that we establish for a number of types of establishments and operations that pose public health threats in our community. Then we mitigate against the spread of disease. And I think people have become quite familiar with mitigation from the COVID-19 response and the masking and social distancing and some of the reductions in the capacities, occupancies at businesses, but other mitigations that we do throughout isolation and quarantine of individuals that have been exposed to diseases. We do also things like mosquito abatement and boil water orders when a water system has been disrupted. And then communications are very important for public health to alert our community to public health threats so they can respond appropriately, as well as to educate them on healthy practices and behaviors. Next slide, please. This slide provides an organizational chart for the health district and the allocation of FTEs across our different programs. We're organized with 4 divisions providing public health services to our community, as well as an administrative health services office and the office of the district health officer. The slide also provides information on the membership of the District Board of Health. And we have about 166 FTEs normally operating at the health district. That's been expanded significantly by the COVID-19 response, and I'll talk about that further. Next slide, please. I'm going to run through the different divisions that provide services. Community and clinical health. The community health component is really the chronic disease prevention program. And in Washoe County, we focus on tobacco and substance misuse, as well as obesity, overweight and obesity, as some of the driving factors for the chronic disease burden that we see in Washoe County. And then our clinical services are really all designed with a public health intention of improving community health and reducing the transmission of disease in the community. So we're not a medical care clinic. We have 2 FQHCs, Northern Nevada Hopes and Community Health Alliance, that provide excellent medical clinical services for our community. But ours are oriented around family planning, where we provide reproductive health services, immunizations that focus mostly on childhood immunizations. We have a small maternal, child, and adolescent health program and a WIC program that provides nutritional support for infants and mothers, as well as education and counseling regarding nutrition and breastfeeding. Our sexual health program works to prevent the transmission of sexually transmitted diseases, as well as testing to identify and then treat those diseases. And our HIV program also involved in testing for HIV and connecting people that are found HIV positive with the appropriate medical care. Our tuberculosis program also does testing and provides treatment for TB, as well as disease investigation of those that might have been exposed to people infected with TB in our community. Next slide, please. Our Epidemiology and Public Health Preparedness Division, of course, houses our epidemiology program, which is responsible for the surveillance and disease investigation functions. Our Public Health Preparedness program develops plans for pandemic response, bioterrorism, radiological attacks, and exercises those plans with community partners. Also, everybody at the Washoe County Health District is trained under the federal incident command system. So we're ready to stand up and function either independently or with partners in emergency response. We have vital statistics, so we're responsible for recording births and deaths in Washoe County, as well as issuing those birth and death certificates. And then in Washoe County, we're kind of unique in that the health district has the oversight of our regional ambulance franchise for services through REMSA. And in addition to that, we also have an EMS program, which is focused on oversight and coordination amongst the EMS partners and our fire agencies, dispatch and REMSA on efficient functioning of the EMS system. Next slide. This is a organizational chart of the different programs that we have in environmental health services. And these are organized to prevent public health threats that are posed by establishments and different operations in Washoe County. So there's a lot of information on this slide. You can see the different types of establishments that we regulate. I just wanted to help out with a few of the acronyms that are on this page. Under food safety, we have the HACCP operational plans. That is hazard analysis critical control points. So these are plans around critical points within a food service establishment for addressing risks that would come out of those. We're trying to take a very risk-based approach with our regulatory oversight for these different entities. Under the food safety, under special events, you see EPI and FBD complaints. We respond to epidemiology and foodborne disease complaints in that program area. Under our commercial plans, permitted facilities, you'll see IBD. We regulate invasive body decorations, so your piercing and tattoo parlors. And then we also regulate what's listed as RV and MHP. Those are our RV and motorhome parks. And then under our waste management functions, you'll see UST. That's underground storage tanks that we provide permitting for construction of. There's a typo under land development. Commercial water systems is properly called community water systems, but most of those are commercial systems that we oversee. So a broad range of services in environmental health. Next slide, please. We're unique in Nevada in that we provide air quality management programs under state statute. The health district is designated to implement the Clean Air Act in Washoe County. And so that's the federal program. And so we have a network of monitoring stations, and we put out daily air quality information and alerts as necessary. We have a planning area where we work to try to prevent deterioration of our air quality in Washoe County. So we have a wood stove program that addresses use of certified clean burning stoves and issuing burn codes when we have inversions. We have also a smog check program and programs to address ozone precursors coming from vehicles. Our permitting program addresses stationary air pollution sources as well as surface disturbances for dust control and demolition and remodeling activities in regard to asbestos abatement. And we do inspections and enforce if we find problems with those permitted facilities. Next slide, please. The Office of the District Health Officer falls under myself directly, and we work to support the Board of Health and their monthly board meetings. We also are an accredited health district. We received our national accreditation in 2019, and so we work with the other divisions across the health district to maintain that accreditation status. We, as I mentioned, do health assessments, and through that work with our partners to identify how we can work together as a community to improve the priority areas we identify in the assessments. Currently, we're focusing on the areas of housing and homelessness, behavioral health, and physical activity and nutrition with a number of community partners with a plan for moving forward and that we've been implementing over the past few years. We lead our quality improvement and workforce development efforts, as well as our communications. And I'm going to talk about that in a little more detail as we get to the COVID-19 information. But I also wanted to acknowledge our government affairs liaison, Joelle Gutman-Dodson. And so you may see her presenting testimony, public comment, or communicating with you during the session. Next slide, please. This is our $24 million budget. This is our budget for FY 2021 without the additional funding that we've received for COVID-19. Our largest funding comes from the general fund transfer from Washoe County at about 40% of our budget. We're also under statute able to charge for fees and for services for permitting and other regulatory oversight activities that we do. We do collect some revenue from the sale of tires in Nevada that supports our some of our solid waste management efforts through the tire fees. And our air quality program is supported through $1 per smog certificate that's issued in Washoe County. And the federal and state grants that compose just over 25% of our budget, that's mostly federal funding that's either direct or pass through through the state. As was mentioned, Nevada has a very low state investment in public health. And so we receive 1.8% of our budget from that state funding that we receive through grants. We have received an additional $16.8 million from federal funds for the COVID-19 response, in addition to this $24 million budget. So you can see that's a significant additional source of funding and a big lift that we've done in the COVID response. Next slide, please. So I'm going to provide a quick overview of our COVID response. We activated our department incident command system back in January 17th of last year. And we had our first case that occurred in March 5th. And then in March, we moved to a regional response. And we've been at it ever since. These show a number of slides of our response. We've learned and improvised as we've moved through and learned more about the disease. And so you see here some historic photos that span our pre-mask days and our mask days in the response. Next slide, please. So since the pandemic started, we stood up a drive-through COVID-19 testing operation, which we had operational within 1.5 days of having our first case identified in Washoe County on March 5th. And we've learned and improved that operation since that day one and have expanded it dramatically. We're now using that same facility that we've established for our COVID-19 vaccination pod. And we set a new record last Friday with 1,800 people that we vaccinated, over 1,800 on Friday alone. We've stood up a COVID call center. We've got 24 people now dedicated to staffing that does the scheduling for testing we do, as well as the vaccines that we're now provides the reporting out of the test results, and does all of the incredible amount of data entry work on the backside of providing those vaccines to get those into the data management systems that the federal government has set up. We've increased our disease investigators from 3 to over 50 to contact the positive cases and have them isolate and identify close contacts for quarantine. And we have over 85 people that are working on our field operation for the testing and the vaccinations that I'll show you some pictures of. So much like what Ms. Aker was talking about in Carson City, space has been a requirement as we've expanded the staffing. When I send out an email to all public health district staff, it now goes to a list of 366 people. And we've taken over buildings B and C of the county, C and D of the county complex, in addition to the building B that we normally occupy. So we've benefited from many people that are remote working, being able to take up some of the space that they used to occupy. Scott Oxerard, who's our communications manager, has done a phenomenal job on communications, and we put out over 330 press releases over the last year. I've held over 60 media briefings over the course of the year. He's led our regional information center. They've created 2 websites, one on the COVID-19 response and the other specifically on the vaccine now that it's available and how we're managing that. And they have several social media platforms and accounts that they've also established. We couldn't have done all of this without the partners that we have. We have the National Guard that's integrated into our operation. We have the CERT, Community Emergency Response Team volunteers, as well as the Medical Reserve Corps volunteers that are helping us with our operations. Next slide, please. So the COVID-19 has really laid bare the social inequities that we have in our community that we've known for quite a while led to poor health outcomes. And what we've seen is that we have communities that are, many people are just at the margin, and they have to work to keep food in their for their families and keep a roof over their heads. So these are essential workers, many of them working jobs that earn them below the median wage. They're not able to work remotely. They don't have paid sick time off. And they often live in close quarters with other family members. And so we've seen a disproportionate impact in our Hispanic community throughout this pandemic. And so I think we also need to understand that the data on testing shows that the number of the Hispanic population being tested is also disproportionately low to the population of Hispanics that we have in Nevada. And so these numbers may not be reliable. I would expect that the number of COVID-19 cases that we have in the Hispanic population have been actually much greater than what we've seen. And then we've also seen this devastating impact to our elderly population, with a number of deaths occurring in that segment of our population. Next slide, please. So fortunately, we're trending better with the number of cases that we're experiencing in our community. And while this figure was from last week, as of yesterday, our 7-day moving average for new cases in Washoe County is down to 90. And our positivity rate has declined to 11.1, which was not so long ago, closer to 22% positivity. So we're grateful to see this. We're not out of the woods yet, and we want to continue to see these numbers decrease, but we think we are seeing some real outcomes of everybody working together, and those mitigation measures and the pause that the governor has instituted. Sadly, we're at 616 deaths that have been reported in Washoe County to date. And I can tell you, when we were surging here in Washoe County, it was very frightening. Our health system was under great stress, and we were seriously looking at the possibility that we would need to be rationing medical care that could be provided to individuals in our community. So I'm very relieved to see these numbers going down as they are. Next slide, please. This is a picture on December 15th of our first shipment of Pfizer arriving at the health district. And we're able to obtain an ultra cold freezer device. So we're able to receive and store the Pfizer as well as the Moderna here at the health district. Next slide, please. And we have a number of points of dispensing, providing vaccine in the community. So we're doing that at the Reno Sparks Livestock Events Center. The Renown has a pod set up at their South Meadows facility. We have a retail pharmacy vaccine program where we have pharmacies that are vaccinating staff and residents of long-term care facilities. And we have community partners that are doing pods, strike teams. So our fire agencies have been engaged in providing pods. Community Health Alliance also is providing vaccines in a pod at their parking lot. Next slide.
And I'm sorry, Mr. Dick, is there any way we can wrap this up? I want to give our members a little bit more opportunity to ask you some follow-up questions. I know that I have some people that have questions.
Okay.
And I know we have to be done by 4, and we have another presentation from Southern Nevada Health District. So is it possible for you to wrap it up?
Yeah.
Members will have opportunities to
I've got just a few pictures. Is really the rest of my presentation. So
thank you.
This is an aerial view of the 6 lanes, about 750,000 square feet that we run at the Reno Livestock Events Center. And the next slide shows you the vehicles stacked up in those 6 lanes and the testing stations that we use. Next slide. These are the Connex stations with the modular roofing that we've had put together. And the next slide shows the inside where the vaccine is dispensed by pharmacists and we collect the paperwork. And the next slide is our vaccine distribution statistics. And as of today, with our pod, we're at over 29,000 vaccine doses that we've administered through the health district. This slide is for the Washoe County total. And the next slide provides you with the website for our vaccination information. If people are trying to figure out where we're at in the lanes or how soon they may get vaccinated. We're maintaining a waiting list for seniors on there, and we have a phone number available, 775-328-2427. So I'm happy to take any questions.
Thank you. Thank you for that presentation. I'm sorry to rush you. I know that we had a little bit of a late start this morning, but there are other committees that start at 4.
Sure.
So I believe Vice Chair Peters has a question. So we'll turn it over to her.
Thank you, Chair, and thank you for the presentation and for all of your hard work. I know Washington County has had a particularly difficult time because our homeless population has been increasing as well as winter months having hit. And so we have this balance right now that I'd just like to hear a little bit about with treating a home and testing our homeless population and managing care for them, or at least having them in facilities that are accommodating to the need, and how you guys are balancing that.
Yeah, thank you for that question, Assemblywoman. And we are working closely with the Human Services Agency and our other regional partners in regard to the homeless population. Some of the pictures that you saw on that first slide on COVID were actually testing that we were doing over at the Reno Event Center. We utilized that facility so that we could provide additional distancing for the sheltered population, since there's limited space that was at the Record Street Community Assistance Center. The county also has been able to stand up the new facilities for women and families at the NAMS campus. So that's an additional capacity there. A men's shelter has been established on 4th Street to increase the area and population that could be housed there. And I think a real positive thing that's come out of this has been the work together across the region on plans for a homeless larger area, a campus and complex, an area called the Governor's Bowl. And then also just on the people that are homeless and have tested positive for COVID-19, we have a contract regionally with WellCare, and they're able to accept those people that don't require hospital level care to be able to provide them with support services and housing during their isolation period.
Thank you so much. And if you have data related to the virus contraction and rates in our homeless population, as well as some of these demographics, it would be really great to see those if you could follow up with staff on that.
I can follow up with you for that.
Thank you. I don't see any other messages about any questions, but if you have one, do you want to wave here on the group chat and I'll be able to call you out? I think we're okay. So thank you so much for your presentation, Mr. Dick. And I will move to our last presentation of the day, which is the Southern Nevada Health District. I believe we have Mr. and our Dr. I'm just gonna butcher it. Yes, I'm going to let you just introduce yourself, and congratulations on being appointed to the permanent position that you have now. So I will turn this over to you. And I know that we have about 15 minutes, but I know our members have plenty of questions as well for you. So I will let you get started.
Thank you. Well, thank you. For the record, my name is Fermin Leguen, District Health Officer for Southern Nevada Health District. Phil, the next one, please. Well, in Southern Nevada, we have our Board of Health. Currently, there are 11 members of the board with representation from the different cities and the county. In addition to that, we have right now more than 680 employees, which is a significant growth from our previous numbers. About 2 years ago, we had less than 500 employees here. There are five divisions in our health district: the community health division, environmental health, clinical services, the administration, and the Federal Qualified Health Center. I should tell you that the Federal Qualified Health Center is a new development within the health district. We received an award from HRSA in September 2019, and we were able to start the QAC operations. And recently, we received a second award from HRSA that allowed our operation for the next 3 years. So right now, we are still developing our health center, but it's already fully functional for the community. Also, we have similar duties than the ones presented by our colleagues before. So I didn't include the slides about the organizational chart or divisions, how they operate. Those are pretty common among the health districts. I can send that to the committee if there is any interest on that. But I just wanted to emphasize some of the areas where we have a different approach, if you wish. For example, we recently, 2 years ago, we started offering here a preventive medicine program, and that's something that was created here because there is a need for preventive medicine physicians in Nevada, and we saw the opportunity to contribute to that effort. So that's a partnership between us and UNLV. The resident spent the first year doing their MPH program there, and then the second year they do the clinical and management rotation here with us at the health district. And we also have been working in other projects regarding opioid reduction. We received a grant from the CDC for overdose data to action, which is something engaged in surveillance and preventive action for drug overdose. And next. This is our budget as it was at the beginning of this fiscal year, in July 1st. It was at $98 million. Our budget currently is $129 million because of COVID. We received almost $33 million from the CDC to support our enhanced surveillance, laboratory activities, contact tracing, and testing. So our budget right now is about $129 million. The federal grant represents about 42% of our budget. So it's a little bit different than what you see because there was almost a 30% increment in our budget because of COVID activities. We do have concerns about our budget coming next year, fiscal year, because our budget normally receive almost between 25 and 28% of our budget is coming from property taxes, local taxes, and our expectation is that those taxes might decrease next year, and that will have a negative impact in our activity. So this is something that we have been talking with the county and I'm monitoring. And also, we're trying to prepare for that for next year. Next, please. This is a picture of our dashboard, and it is available online. And this is the site where we share information with our community and anybody all over the country who has an interest in our data. So we have there the current number of cases that have been reported in Clark County, and also we have the hospitalizations and deaths on that side, and then in the main area of the dashboard, there are seven areas where people can click and get additional information, whether it is cases. Also, we have a sick data by sick code information mapping, so people can look at the area there, and also in the area of characteristics, people can look at trends. And then the last thing that we incorporated into our dashboard was the place of possible exposure. And there we share with the community the areas that our cases report as being visited within the last 14 days. So, and that's something that we utilize with our environmental health division, and also with our disease investigation team, just to try to work in certain facilities that might come in repetitive numbers through this question. But we use that information in conjunction with additional data that we receive from our patients. And then, of course, this is the trend of the pandemic in Clark County from last year until now. For the last few weeks, we have seen a very deep decrease in the number of cases, and we hope that it continues that way. Next one, please. And this is the incidence of coronavirus in Clark County by race, ethnicity. And what we have seen in Clark County since the beginning of this pandemic is that the Hispanic population has been the one with the largest impact in terms of cases. And this has been very consistent through the pandemic. Something interesting with the Hispanic population in Clark County is that this high incidence that they show actually doesn't translate in mortality. Actually, mortality for Hispanics in Clark County is the lowest among the different racial and ethnic groups. Thank you. This is our zip code map, and this is something that we use in addition to the cumulative one for the whole pandemic. This is we use for this one more recent data, the last 14 days. So that help identify new areas that could be affected by the pandemic. So what you see here is that most of our high incidence areas are in the central part of the county. Those areas belong mostly to City of Las Vegas and City of North Las Vegas, and mostly what you see to your right is the east area of Las Vegas, zip code 89110 and 142 and the others. So those are the areas where we consistently have seen the largest impact of the pandemic. These areas also are highly populated by members of the Hispanic community as well. Next one. Yeah, and this is, of course, the first day that the vaccine arrived to Clark County. It was December 14, and we distribute the vaccine immediately as we received that. Actually, that very first day, we had a pod at one of our local hospitals, and then we continue distributing the vaccine through the valley during that week. I also want to mention that for the vaccination campaign, we have developed a very strong partnership with the county and local jurisdictions. We also with local universities, Toro, UNLV, Roseman University, also the College of Southern Nevada, and other institutions. All of them are participating in the pandemic, whether it is supporting pods or providing staff to participate in our operations. We also have met with representatives of the church of all over the valley, and also a business community, and also representatives for the Hispanic and African American and communities as well. Even we also have communications and presentation with the Asian community, to the Filipino Nursing Association and the partners. So at this point in Clark County, we have administered more than 200,000 doses. Actually, until yesterday was 214,000 doses. Those vaccines have been offered all over the county. We have a big vaccination sites at Cashman Center, and also we offer at the Western High School and Mac Middle School, which is in the east side of the city, also El Dorado High School, and recently we opened the Las Vegas Convention Center to offer second dose vaccinations. I also wanted to share with you some data regarding the vaccine here. In terms of gender, 58% of the people receiving vaccine are females, and I think that's perhaps because of the weight of the healthcare workers into this population. Healthcare workers at this point represent more than 40% of the individuals who have been vaccinated in Clark County. Also, in terms of race ethnicity, 41% are white, 10% Asian, 10% Hispanic, 6% African American, and then we have about 30% of the individuals who are either older or unknown. So it really makes complicate the issue of race ethnicity analysis, but it's important to know that. And in terms of who administered the vaccine, 64,000 doses have been administered by hospitals, which represents more than 30% of those doses, and 88% by the health district and CASMA. Please, the next one. And this is a zip code map where we show the distribution of doses in Clark County, and what we wanted to highlight here is that until last week, the numbers in Clark County of vaccine distribute don't match what is happening with the incidence of coronavirus in Clark County. Next one, please. So the next, here you can see to your left is the incidence zip code map, and to your right is the vaccine administration. The vaccine administration is not matching geographically the incidence by zip code. As many of you are aware, or all of you probably are aware, there were recent comments or declarations about health inequality in Clark County and the way that we distribute the vaccine, and I believe that that was an unfair comment, because until now, more than 40% of the vaccines have been distributed to healthcare workers who have a very high number into the vaccinations. Also, we have issues with the race ethnicity in terms of the weight of the unknown and others. Now, having said that, we do have a plan on how to address health inequalities in Clark County, and some of the things that we want to do is to in addition to the large mega vaccination sites that we have and plan for the future, we will be targeting those zip codes, those communities with smaller teams, whether it is mobile units or close spots in collaboration with elected officials and representatives for community-based organizations or church or those areas, that will allow us to, when we offer the vaccine in one site, most of the population who receive the vaccine there will be the one who actually live in the area. And this is an issue that is important to mention, because for example, last week I was reading an article from the New York Times, I believe. They were discussing health inequalities in the country, and they brought the example of some large metropolitan areas, and the common denominator in that analysis was that the large vaccination sites have been deployed mostly in affluent areas, because it was easier for them to do that. That's not the case in Clark County. Our spots are all within the areas where we have more cases. Cashman is just in the middle of all that action. Also, all those schools where we have open pods. The thing is that the registration is open to everybody, and we want everybody to register. So those large vaccination pods don't allow for that kind of control. That's why we will emphasize the small operation when it comes to health inequality.
And I'm sorry, Doctor, we are about to get kicked out of this, and I want to make sure we have an opportunity to get to our public comment. But thank you so much. I know that there were some people that had some questions that you answered them in the middle of your presentation. I did have a request from several members, and I'm hoping you might be able to do that. And this goes for some of the other agencies that may have presented if they are still on the line here. I was wondering if you had any kind of breakdown by our assembly districts of the COVID positivity and vaccination rates that you might be able to provide to our committee staff, so we can bring those over to our members. I'm not sure if you have that or if it's just listed by zip code. If it is by zip code, I know people can go ahead and get that information, but if you do have it or have the ability to do that fairly easily, that would be the request.
Yeah, what I will do is I will ask our data people, because that most likely require like a census tract because zip codes very unlikely will match the area, but we will look into how to simplify that. Okay.
Thank you. Thank you so much. And
Sure.
thank you for your presentation. I know a lot of times people didn't know exactly what the health districts did. Obviously, we know what they are all responsible for, and now we have a pandemic on that they're also responsible for. So we do appreciate all the challenges that you are doing and the unique and creative responses that all of your agencies are trying to accommodate and, thrive in this situation. So thank you so much. So with that, I'm going to close the presentations and broadcast. Do we have anyone on public comment?
Chair, the line is open and working, and there are no callers at public comment at this time.
Okay, wonderful. Well, I will close public comment. And just some business, I was probably a little optimistic for Wednesday's agenda. As you can see, we're doing an overview of mental health in Nevada, as well as the Division of Public and Behavioral Health. I have asked them to kind of keep it to some topics that I think will be important for us to know as a committee going forward with some of the bills that we will be seeing. And we will have very, very short presentations from the regional behavioral health policy boards. Because I am trying to avoid having a meeting on Friday, and I think I had laid out that I want to try to be as efficient with our time as possible, I would ask everyone to come prepared for the two bills that we are going to be hearing. One is Assembly Bill 62, and I'm going to send out an email to the committee, but I would recommend that in preparation for Assembly Bill 62, if you have if you want to obtain more information about the Nevada ABLE Savings Program. This was addressed last session with Assembly Bill 130, and I'm going to have Patrick Ashton send an email with some links. So if you want to get a more overview of that existing program and how so you'll be prepared to hear AB 62 on Wednesday, I think that would be beneficial. And we also have our first personal BDR, AJR 1, from Assemblywoman Titus that will also be presented on that day. Again, I would encourage everyone to reach out to our policy analyst or legal, Carly O'Krent. If you have any questions, they might be able to prepare and do some of that research in advance. If you're reviewing those bills and have some specific questions about, any legal questions, I would ask you to reach out to them. So with that, do we have any comments or questions from the committee members? And I am putting it in a full screen gallery view so I can see. If you can wave if you have any questions or comments, that would be great. I don't see any here. So with that, meeting adjourned.